Yeah. Can we quickly have a word of prayer?
Hi.
Hello.
How are you? Can you hear me?
Good morning, everybody. Welcome to the international webinar at Believers Church Medical College and Hospital. A warm welcome to all our faculty and students, undergraduates, postgraduates, faculty and guests from all over Kerala and beyond, our international diaspora and partners in education. Today, we have two distinguished clinicians to moderate the session. Dr. Joseph John is our senior consultant in general medicine, who after completing his MBBS from TD Medical College, Alleppey, went on to do his MD internal medicine from the prestigious CMC, Ludhiana. He dedicated his early career of practice to mission work at Landor Community Hospital, Missouri, and later shifted to Century Hospital at Chenganur. After a brief stint at a polyclinic, he joined the elite general medicine physician group at Believers Church Medical College Hospital. Brilliant clinician and wonderful human being with loads of compassion. Sir, we welcome you to this international webinar. Next, we have the head of clinical services at the Believer City Clinic, Dr. Philip Thomas. After completing his MBBS at Government Medical College, Kottayam, he went on to complete his MD internal medicine at the prestigious CMC, Ludhiana, and then served as lecturer in medicine and later in endocrinology. He later worked as consultant physician at Tiruvalla Medical Mission, Kerala, and also at Sanctuary Hospital, Chenganur. He is primarily interested in diabetes and endocrinology. Compassionate clinician and an amazing human being. Sir, we welcome you to the webinar, and may I request you to welcome our international speaker for the day to the gathering. Over to you, Dr. Philip Thomas, sir.
Thank you, dear Jacob, for those kind words of introduction. A very good morning to my respected teachers, colleagues, and friends here in India. And wishing you, Georgie, a great evening at Boston. And to all our colleagues, a great good evening all over the world. No greater opportunity, responsibility, or obligation can fall to the lot of a human being than to become a physician. In the care of the suffering, the physician needs true skill, scientific knowledge, and human understanding. We are confident that the next 90 minutes or so are going to be one of a kind, sharing the latest trends in SARS-CoV-2 infection, an active discussion of the myriad presentations of this rare pestilence. Yes, it has been a nightmare for the patient as well as the physician alike. And to solve this conundrum, as our boss put it, as we have titled this talk, we have none other than Professor George Abraham, Chief of Medicine at St. Vincent Hospital, Worcester, Boston, and Professor of Medicine at the University of Mass General Hospital, Boston. And I'm proud to say that he's the only Asian to be elected President of the American College of Physicians, the largest body of internists world over. He previously served as Emeritus Chair of the Board of Governors and as the Governor of Mass General Chapter. He's also the Chair of Infectious Disease Board of the American Board of Internal Medicine. In this capacity, he oversees the certification of diplomates in the specialty of infectious disease. His research interests include hepatitis B and C disease, travel medicine, and infection control. Dr. George has authored over 100 publications and is a speaker at various international fora. He earned his medical degree from the Christian Medical College, Ludhiana, completed his residency and chief residency at St. Vincent Hospital, Worcester, Boston, and his master's in public health from the famous Johns Hopkins Bloomsburg School of Public Health. We had the rare privilege of being contemporaries at the prestigious Christian Medical College, Ludhiana, during our postgraduate days, and now as a trio, proud to uphold its legacy. You'd be surprised to note that Professor George is also an accomplished musician and an organist. And now, on behalf of our manager, Reverend Father Sijo Pandapallil, our Chief Executive Officer and Chief of Gastroenterology and Hepatology Services here, Professor George Chandy, our principal, Professor Sam Chittaranjan, and from all our revered faculty, I extend to Professor George Abraham a hearty welcome. Professor George will share in the next 45 minutes or so about the disease and its management, his experience managing umpteen patients, and the scope of the vaccine which is to be released, and overall, very important, the public health issues. I now hand over the session to Professor George Abraham. Georgie, please.
Thank you, Philip, for that very kind introduction, and a good morning to all of you. It is 10:30, it's 11 o'clock actually in the night here on Friday night here in Boston. And I'm very grateful and honored to be joining all of you in this scientific session. Thank you for inviting me. I'm personally honored. A number of people, Philip and Jojo, are my colleagues. We've grown up together and obviously had a number of different experiences together, both scientific and also in music and many other experiences. We've shared warm memories of our times together in CMC Ludhiana. I'm also grateful to a number of other faculty at your institution who are faculty and mentors to me in my training at CMC Ludhiana. And I'm also grateful to Dr. George Chandy for his personal words of welcome. He had emailed me in inviting me to present today. What I'd like to do is run through the subject and then probably spend a few moments in question and answer to address some of the issues. Needless to state, we have more questions than answers at this point in time, given the relative nascent nature of the epidemic. But as information keeps evolving, it's critical that we change the way we handle and our approach to both management as well as public health mitigation, which is critical to controlling the epidemic. I have no disclosures to make. The pandemic was probably the most unique experience that we've all gone through, probably a unique one for our lifetime. If you look back, the closest to this was the flu epidemic of 1918, which was approximately 100 years ago. And the prediction is we would have a pandemic about once every 100 years. And so 2020, we are in our pandemic as predicted. The pandemic continues to grow, and this is a little while ago, about an hour or 2 hours ago, I updated this slide from the Johns Hopkins Center for Coronavirus Research, which monitors all the cases worldwide and updates its totals. In the United States, it's still the #1 country in the world with the highest number of cases, both deaths as well as cases. India is #2 in the world now. It has overtaken Brazil in the number of cases. And then the other countries are as follows, but just to show you the magnitude of the epidemic. SARS-CoV-2 belongs to a family of viruses called coronaviruses. It's a beta coronavirus, and that's where this originates from. Coronaviruses have been in existence for several years. We've known of them all along. I'll show you some of the other family of coronaviruses as we go along. So the coronavirus family is not new to humankind, but the SARS coronavirus, which is a mutant, is definitely new to the humankind. And its closest family members were the original SARS virus, which you may recall from 2003 or so. And then in between, we had what's called the MERS virus, which was the Middle Eastern Respiratory Syndrome virus, both of which had two different intermediate hosts, SARS being bats and MERS being camels. So technically, this virus is actually a virus of bats, and the animal is an accidental intermediate host. So it could be civets, it could be some other smaller animals, or if it was MERS, it was camels. And then subsequently it mutates again to infect human beings. And so who are the end hosts in this? And subsequently from humans, there's human to human transmission, which has been well documented now. Originating in the city of Wuhan in China, it has now spread worldwide. The timeline, even in the United States, so somewhere around the end of December, that China notifies the World Health Organization, and the US recorded its first cases somewhere towards the end of February, the beginning of March, and subsequently then it has marched worldwide, and almost every country in the world has reported cases. So as I mentioned earlier, SARS is a virus that primarily resides in the bat respiratory tract. It's believed that there was some mutation of that virus to make it more susceptible to then invade either another animal like a civet or a pangolin, which is an intermediate small four-legged animal. And then it mutated again to become the human virus that it has now become, which infects human beings. Early in the sequence of events of this virus becoming worldwide, based on our experience with SARS in 2003, what was done was China sequenced the genome completely and put it out in the open domain so that people could all start developing treatments. So this sort of scientific collaboration between different countries in the world has revolutionized and accelerated treatment options and exploration of vaccines, where otherwise everyone would be secretive about development of the treatment options. So the virus as we know it has at least three main domains that we are most concerned about. The E protein or the envelope protein and the N, the nucleic protein, are the two which form the basis of most of our antibody testing. The S protein or the spike protein is the most critical component. It's an integral part of the virus and is needed for attachment to the host cell. It's also the part of the virus that is being looked at to develop vaccines because it's the most antigenic component of it, as I'll show you momentarily. The membrane protein is of some interest, but has not really panned out into being something which would be useful either from antibody testing development standpoint or vaccine development standpoint, primarily because it cross-reacts with a number of other proteins and therefore does not confer immunity. It's estimated that SARS-CoV-2 or COVID-19, as it's now been called, falls somewhere in infectivity between the flu and the original SARS, so somewhere in between in terms of infectivity. And when we talk of infectivity, we talk of what's called the basic reproduction numbers. So how many people does it need for the virus to multiply and to infect? And to give you a scale of comparison, you can see all the way from as low as 2 in Ebola to all the way as measles being in the 20s. So highly infectious virus, measles, a lower infectivity is Ebola. Ebola is much more deadly. measles is much more benign, and all the others sort of fall in between. So if you look at that standpoint, the infectivity of coronavirus is approximately 2.7. So one individual can infect about 2.7 individuals, but then they in turn go on infecting others. And so therefore it multiplies rapidly, also because the mode of transmission is airborne, as you can see in this graphic. So it's respiratory droplets of varying distances. And that distances, the initial feeling was that, okay, it's only transmitted for a short distance. The distance of 6 feet is a conventional distance that was developed from the earliest flu epidemics. And at MIT, the Massachusetts Institute of Technology, one of the most prestigious engineering institutions in the world, which is located in Boston, there have been several studies quantitating what is the total distance that virus travels from the time it exits a person. So clearly, with just simple respiration or conversation, about 6 feet seems to be reasonably appropriate. But the moment there is coughing or there is shouting or singing, that is a forced expiration of a much higher magnitude. Distances of up to 35 feet have been documented. So clearly the 6 feet distancing is no longer operative. And the significance of this, as I'll show you later in the presentation, is the settings in which this may apply. For example, churches are one of the areas. So churches have gone virtual by and large for many parts of the world, because congregate setting in a church with singing, with chanting, with praying loudly, etc., there is a much more forceful expiration of virus, and the aerosol travels a much higher distance. The pattern of viral shedding mimics that of flu. The initial phase of the illness has the highest density of virus, and as virus progressively dies out, the degree of shedding progressively decreases. And so it's important to review that and to think about that, to understand that the initial phase of the illness is what we call the viral phase of the illness. The other conundrum in COVID-19 is what are called super spreaders. So we clearly understand that everyone in whom we detect the presence of virus based on a nasal or a nasopharyngeal swab does not always transmit. There is only a small minority who transmit and who may transmit extremely effectively. Our problem is we are not able to identify who those effective transmitters are, or what are called high viral shedders, and who will be low viral shedders. So we just need one person who's a high viral shedder to essentially transmit to a large number of people, who therefore are called super spreaders because of their ability to infect large numbers of people. So the challenge is to decide who is a high shedder, and that's not easily apparent, nor is there testing to document that, which is why we need to do this universal sort of lockdown mechanism or distancing to be able to control the spread. This is probably one of the fundamental aspects of understanding the natural history of illness. There are two phases that we would document in the illness. The initial phase is what's called the viral phase of the illness. This is when viral shedding is maximum. And as you notice that over time, that viral shedding progressively decreases. And what you see is the inflammatory response, which is trying to control the virus multiplication, takes over and becomes what we call the inflammatory response, otherwise known as the cytokine storm. So our treatment interventions are therefore geared towards the phase of the illness. So all our antiviral therapy should be geared early in the illness, and as more advanced phases of illness occur, such as the increased respiratory distress, they end up going on a ventilator, they become worse in terms of the cytokine storm. Our antiviral interventions really don't work at that point in time. You're trying to mitigate the cytokine response, so it might be too late. So again, keeping this in mind is critical as we talk about treatment options and the timing of treatment, understanding this phase, so to speak, the phases from the viral phase to the inflammatory phase will be critical. So we do understand common symptoms, the sore throat, the shortness of breath, the fatigues, the myalgias, headaches, etc. Cough is the commonest symptom and fevers associated with it. Cough is also a concerning symptom because of the risk of potential transmission. Unusual symptoms are diarrhea and runny nose, etc. So coryza-like symptoms are not usually suggestive of COVID. Diarrhea can be associated, and virus has been isolated in the stool of people who are infected. However, there is no documented transmission which has occurred from stool or contamination of stool on surfaces or otherwise leading to spread of virus. So the efficiency of spread is clearly aerosol-based or airborne. I'm just listing here, this is from the initial Chinese cohort of over 1,000 cases. This was the relative spread of frequency of symptoms. We pretty much know this well enough by now. And we know that there are other parts of the body that could be involved, the nervous system. So anosmia, loss of smell and loss of taste are virtually diagnostic in this day and age in the setting of COVID-19 and the epidemic, because that seems to be unique symptoms to the nervous system and to COVID-19. The lungs being a key area where virus multiplies, and we'll talk about that in a second. Kidneys are another key area, and obviously other organs of the heart can be affected, other organs of the body can be affected as well. This was a nice graphic drawn of a respiratory cell, which is the larger umbrella shaped here. And this is how virus multiplies and basically breaks out of the cell. This is all daughter viruses breaking out to show you how respiratory viruses, respiratory cells are probably have the highest affinity for it. And the reason for the highest affinity is because the virus binds to what's called ACE2, angiotensin converting enzyme 2, which has a high proportion in the respiratory tract, which is why the affinity for the respiratory tract. Electron microscopy, so this is basically the cilia of the respiratory tract, what you saw in the earlier graphic, and this is mucus on the cilia. But if you were to look at a higher magnification, here are the cilia, and you see millions of viruses that break out of one cell. Approximately 3 million viruses produced from a single respiratory cell. This is all daughter coronaviruses budding out of the cell to show you how efficient the respiratory tract is in both multiplication of virus and the spread of virus. Laboratory abnormalities are also listed here, none of which is new to people who are familiar with this, so I'm sure you've seen all these yourself. Lymphopenia and thrombocytopenia are well described. The chest X-ray abnormalities and the CAT scan abnormalities are virtually diagnostic. In fact, so much so that during the original epidemic in Wuhan, it was faster to get a CAT scan. And so if a CAT scan showed abnormalities, they basically assumed that that was COVID-19 and never bothered to even get testing for the presence of antigen, suggesting that this was so prevalent and widespread. And this is what it looks like. Early shows some of these early shadows. So it's an interstitial pneumonia which is developing, and it progresses to form a more extensive pneumonia, essentially wiped out of both lungs as the respiratory phase advances, leading to severe respiratory difficulties and the need for ventilatory support. This slide shows you really where in the phase of illness that you see the respiratory abnormalities. So in blue are people in the early phase of illness. In orange is the intermediate phase of illness, and is in gray the advanced phase of illness. So as you can imagine, early in the illness, there may not be much of respiratory manifestation. So you have normal CAT scans. But as more advanced disease progresses, you see a more spread of illness. So in the late phases, you see how the proportion of people who have CAT scan abnormalities markedly increase, and people who might have a normal chest X-ray or chest CT are much, much lower. Essentially trying to state that as the disease progresses, it's the inflammatory component which contributes in a large part to what we see as radiological abnormalities. And this is just showing you a progression over time to show you how it progresses to cause such overwhelming consolidation of the lung spaces that there's virtually no clear space, so no air exchange happens. And you can see that it gradually wanes down over a period of time as they recover from the illness. There are other complications that are of note, specifically the acute kidney injury, sepsis, the adult respiratory distress syndrome, ARDS, the need for mechanical ventilation. And by the time they need extracorporeal membrane oxygenation or ECMO, its survival rates are less than 1%. So it is extremely dismal by that point in time, and prognosis is critically dismal. So ECMO is really cosmetic, at least in our experience here in the US, and rarely life-saving. There are exceptions to the rule. What is well described is that the CD4, CD8 response to COVID-19 or SARS-CoV-2 is much more robust in younger people, and in older people, in men, and in people who have comorbidities, that response is markedly impaired. That may be one explanation for why there is a preponderance of disease in men much more than women. In people who are older tend to have more severe disease because the immune response is significantly weaker to SARS-CoV-2 in people who have more advanced illness, such as diabetes, hypertension, or other comorbidities, age, and male gender. So they are the three poor prognostic factors or leads to higher propensity for disease. There are other immune-mediated characteristics that are typical. In general, the lymphocytopenia, as has been well described, the presence of a number of inflammatory markers, the cytokines that are described, which is TNF-alpha, the NF-kappa beta. These are all inflammatory markers which are driven as part of an immune response. Interferons, which are secreted, and I'll address interferons separately because that's a hot area of research. And obviously the presence of a higher viral quantum in the blood. So also being looked at is the kidney as a potential repository of viral replication. So not only is the respiratory tract, but the kidney may be the other place. And even though the kidney is the potential area for viral replication, it's not clear that the virus is shed in the urine, nor is the urine any more infectious than respiratory secretions. Respiratory secretions still remain, by and large, the abundant source of infection. Neurologically, yes, definitely well described in nervous system tissue, and the anosmia, the loss of smell and the loss of taste, is believed to be representative of the neurological involvement, other than the vascular events that we see. The vascular events occur, or the hypothesis is that in addition to ACE2, the virus also consumes heparan sulfate, and so therefore causes a procoagulable state. So which is why heparin, which releases back to heparin, so that heparin seems to be useful in reducing the number of strokes that have been associated. The initial data came out of New York, and subsequently many other places. We now have a protocol where we would anticoagulate these patients, usually with standard dose to begin with, but thereafter we go to 1.5 times or even twice the standard dose if we were to see that they were developing vascular events. And this is the hypothesis behind why vascular events, a procoagulable state, develops with COVID-19. There are long-term complications described. There is a lot of scarring which develops in the lungs while the person heals, leading to prolonged recovery. Their ability to breathe, their pulmonary capacity, their exercise capacity, all take a long time to recover. And that could be because of the scarring which occurs post-inflammation in the lung. Our diagnostics are either testing for the presence of viral antigen or testing for the presence of antibody. To make a diagnosis, we need to test for viral antigen. Testing for antibodies is an indirect marker of essentially confirming immunity. It is not useful to make a diagnosis of active infection. So we do need antigen-based assays. So the commonest uses polymerase chain reaction assays. People do use enzyme immunoassays, etc. They are less sensitive and tend to be non-specific and to cross-react with a number of plasma proteins and therefore be much more insensitive. The polymerase chain assays are much more accurate. So polymerase chain assays essentially, so we say what specimens are appropriate. A nasopharyngeal swab is the ideal specimen because the virus multiplies and there is high degree of viral burden in the nasopharynx. A nasopharyngeal swab is not a comfortable test to perform. And so you can see that the swab goes all the way through the nose to the back of the throat to be able to get that. So there have been several studies now which look at nasal swabbing. So just the anterior nares, if you were to swab, the amount of virus and the predictability of the test is equivalent to doing nasopharyngeal swabbing. And so we have switched to all nasal swabbing right now. There are people who do oral swabbing. If you were to do oral swabbing, it has to be from the tonsillar pillars. It should not touch the tongue, or it should not touch any other part of the mouth because the virus, it gets contaminated and then gets less predictable. There are people who are looking at saliva testing, so spitting into a cup. But if that were to be done, they should not have eaten or drunk anything for at least 30 minutes prior to the test. And that also then doesn't correlate as well as a nasal swab. So we've switched to nasal swabbing. And right now we are doing provider nasal swabbing, which means a physician or a nurse or somebody does the nasal swabbing. But essentially, you could go to what is called observed self-swabbing, where the patient does their own swab and the physician or the nurse stands at a distance of 6 feet or more, at which time you don't need to use all your personal protective equipment like an N95 mask, etc. Standard protection, which is a standard surgical mask, would be more than adequate because the chance of aerosolization is much less because we are 6 feet away. So that's where we're moving to. So to conserve PPE, people are moving to self-swabbing. So, and the nasal swab is very easy to do self-swabbing. Nasopharyngeal swab, definitely not. Once a swab is obtained, what happens to it? It goes to the lab. Basically, the virus is an RNA virus. So what is done is it's undergoes what's called reverse transcription. So you make the virus generate DNA by using reverse transcriptase to convert the RNA to the DNA. That DNA is then exposed to a number of other DNA targets, which are based off the virus, and you develop antibodies, which are measured. The antibodies are measured usually with light. And so we count every cycle generates a flash of light and you count it. So what you would have probably heard of is what's called the cycle threshold. How many cycles does it take to be able to replicate or diagnose the presence of virus? So as you can imagine, the higher the number of cycles it takes to be able to quantify virus, the lower the viral threshold. They are inversely proportional. The less number of cycles it takes to expose the virus, the higher the burden of virus present in that specimen. So a cycle threshold is used as a semi-quantitative measure to be able to diagnose when the person might have active virus versus inactive virus, or low burden of virus versus a high burden of virus. So a general cycle threshold, I understand that in India, the ICMR has suggested it be around 35. Here we use 40. Some labs use 45, but essentially whatever, somewhere between 35 and 45, if we were to have a cycle threshold, which many of these PCR-based assays are able to count and give you a count on each specimen to tell you what the cycle threshold is. So that cycle threshold could tell you if there is presence of active virus and how much the burden of that virus is by essentially counting the cycle threshold number, the number it takes to be able to expose active virus. So that is important to also when we look at in people who are what we call persistent positives. So once we diagnose somebody as COVID-19, we do not do a test of cure. We do not repeat the antigen testing or the PCR-based testing after to demonstrate that virus has disappeared and they are cured. And the reason for that is based on a nice study from South Korea, which originally showed this, was that they did swabbing of people who had active disease and essentially demonstrated a number of people continue to have inactive viral antigen within the nose and carry it for long periods of time, 30, 60, 90 days or more. But they concomitantly did antibody testing on all those people and demonstrated presence of positive antibodies. And as I will show you momentarily, by the time somebody develops antibodies, they have no active virus in the system. They are mutually exclusive. So therefore, what they demonstrated was what is present is inactive viral antigen. So here in the US, the recommendation to do a test of cure has gone out. We never test for cure. We would do antibody testing to demonstrate immunity, but we would not do a test of cure. We would only do this testing for purpose of diagnosis. Number of different tests are available. There are take-home tests. There are basically rapid tests, somewhere between 15 to 45 minutes to do a rapid turnaround test, to all the way to conventional testing, which can take anywhere between 2 days to 6 days, depending on the volumes of test requests that come through. This is the other fundamental piece to understand in the natural history of illness. In blue is the natural phase of illness. From time zero, there is an asymptomatic phase during which viral burden builds up in the nasopharynx. We say that the pre-symptomatic phase is at least 48 hours, maybe longer. So that may be a time when they have no symptoms, would escape detection, what we would call the asymptomatic carrier, but will have enough virus that they can infect people. And then they develop symptoms, by which time the amount of virus climbs in the system, reaches a peak, and then the viral burden progressively wears off. What you see in green is the IgM antibody response approximately 7 days into the illness. So this is by the time the viral phase is coming down, you start developing IgM antibodies, and concomitantly, the viral phase starts coming down. And then 2 weeks later, which is where the convention of about 14 days of illness came, that about 14 days, you start building up IgG antibodies, which are demonstrated to be protective antibodies, which confer immunity, stay positive. The total duration for which those antibodies stay positive are variable, could be between 3 to 6 months, maybe longer. We do not know that conclusively yet, but that's being looked at. But the IgM disappears usually within 3 weeks. So if you were to measure for the presence of immunity, depending on when you chose to measure, you may lose the IgM, but you always would pick up the IgG. So earlier in the illness, you would measure the IgM. Later in the illness, you would measure the IgG. So as expected, this is what would be your marker of immunity. You would not be looking for viral antigen at that point in time. This is a study from Hong Kong, which looked at even flu to show the variability period of infection, to say that the immunity is variable from person to person. There is no standardized period, and the blank spaces are essentially the period of immunity before each infection is picked up. So just to say that that immune phase is still being studied, and flu and common cold is the other coronavirus, which is why it's listed as the coronavirus. So the family of coronaviruses. So we definitely know influenza, we definitely know measles, and we have then SARS, and then we have the common cold. So on average, we say immunity for common cold about 6 months. Measles, we know definitely is lifelong. Flu is about 6 months. The life of the vaccine is also about 6 months. SARS, we know was 24 months. SARS-CoV-2 is what we do not know yet what that final duration is. which would be also the basis of the frequency of repeating vaccine when vaccine becomes available. Everyone has probably heard of CRISPR technology. So CRISPR technology is the clustered, regularly interspersed short palindromic sequences. So essentially CRISPR is a basis of using molecular editing. So on the CRISPR associated gene, and which is gene 9, it works like a scissors, and you can cut out sequences or periods of sequences, create antibodies, which in turn induce antibodies that kill the viral antibodies. And so therefore, there are now CRISPR-based testing, which is most recently being done in the US, being trialed. It's not commercially available, but people are looking at novel technologies to increase the sensitivity and specificity of the tests that are available. So what do we do for treatment? Mild treatment, where you don't require hospitalization, we would treat them with just symptomatic treatment, no other therapeutic interventions, and people will recover completely. Obviously, the exceptions to the rule are people who are older, as I talked about, the male gender, and people who have pre-existing lung disease, diabetes, immunocompromised hosts, etc. If people have more significant disease, which requires hospitalization, so that is the pre-inflammatory phase. Recall again the slide which I showed you about the viral phase and the inflammatory phase. So we start our treatment with remdesivir during that viral phase. And I'll show you what remdesivir is and how it works. But essentially, the data, even from our own institution, shows that the later you wait to start remdesivir, the poorer the outcome and no response to therapy. By the time we hit the inflammatory phase, the only drug which works is dexamethasone or steroids of some sort. And because you're looking at basically the cytokine storm that you need to suppress, you're really not looking at controlling virus at that point in time. So earlier intervention with remdesivir is what our current data support. And later in the illness, when people are more critically ill, it's steroids and other supportive care to treat the ARDS like we would manage. So the question that has always been raised is, what about hydroxychloroquine and azithromycin or ivermectin, which was the other study done? And it's my understanding that that is still being recommended in some places in India. So let me show you what the data is. So there were several studies done in the United States, none of which were that robust, till all of a sudden we were all surprised when there was the study published in the Lancet sometime in July, which compared this large database of patients and looked at hydroxychloroquine and azithromycin. And so to explain, this is what we call a box and whisker plot. So this is looking at estimated risk. So risk of 1 meaning that there is no risk of survival or risk of death. So there is neither. Anything to the right of 1 means that there is survival. Anything to the left of 1 means that there is potential death. If you were to look at it the other way, anything to the right of 1 indicates a benefit for treatment. Anything to the left of 1 would be considered a harm to treatment. So if you were to look at this data, this is on survival. What they did was flipped around the database to essentially say everything to the right of 1 showed an increase in risk of death. Everything to the left of 1 was an increase in survival. So looking at that, you looked at in a number of diseases such as arrhythmias, diabetes, etc., clearly showed that there was an increased risk of death. So we knew that anyway from our earlier studies. It seemed to demonstrate that the use of statins, ACE inhibitors, etc., seemed to have a protective effect, which was surprising because other studies did not corroborate that. We knew that certain races were associated, at least in the US, the Black African-American race was definitely associated with increased risk of death, and they seem to suggest the Asian race was associated with a less risk of death. Additionally, people looked at the benefit or risk of developing ventricular arrhythmia and showed that there was an increased risk of ventricular arrhythmia, especially in people who had existing coronary artery disease and in people who were using hydroxychloroquine or chloroquine alone, which was the big challenge with why the drug was not found favorable, because the cardiovascular mortality outweighed any potential benefit. Everything on the margin or on the line of one indicates no benefit or not statistically significant. Each of these are called box and whisker plots. This is the box, is the dot in the center. The whisker is the line on either side. The length of that line represents the 95% confidence interval on either side, 2 standard deviations on either side of the mean. That's what the distance of that is for each of those variables. And the confidence intervals are listed here for your reference. However, there was an astute physician out in Africa who questioned the data when it was produced and showed a large number of cases from Africa that no one in Africa was aware of, and none of the hospitals in Africa had reported cases. So that made them send a query to Lancet, which was the journal that published it, and asked where the basis of the data is and whether the data could be made available. So the journal editors then asked the authors whether they could make the data available. And that led to a scramble. And essentially, the data set claimed that they had at least 3,000 hospitals across the globe reporting data into this large data set called Surgisphere. And they demonstrated basically that the underlying data could not be retrieved. The company Surgisphere essentially claimed that the hospitals were not willing to share that data, so they couldn't produce the data. And ultimately, the journal editors retracted the article, saying they cannot substantiate the results of the study. The 3 authors of the study, unfortunately, are all of Indian descent, and so created a fair degree of skepticism in the US circles. Mandeep Mehra is from the Brigham and Women's here in Boston. He's a cardiologist. I know him personally. He was the lead author on the cardiovascular component of the study. And the Surgisphere was this company created by this physician called Sapan Desai, who's born and brought up here in the US, but of Indian descent, and created this company. And he said that he had this artificial intelligence, which was able to create large data dumps into his company called Surgisphere, and was from hospitals as far away as Australia who were collaborating with him. However, when people reached out to the Australian hospitals, none of the hospitals acknowledged that they'd even heard of this company, leave alone collaborated with him. So that raised questions. The other author on the study, Amit Patel, who's a professor at the University of Utah in Salt Lake City, he lost his faculty position when this results of this was released. Mandeep Mehra is holding on to his position at Harvard still. We do not know whether there will be an impact. And Sapan Desai has disappeared, gone underground. He's not contactable or traceable anywhere. And the company is basically, he claimed the company had thousands of employees. They finally discovered it had only 5 employees. So essentially, the whole study was fraudulent. And so the New England Journal quickly followed suit and retracted their version of the study, which was the cardiovascular effects of hydroxychloroquine. And the NIH then came out with their own study, which demonstrated no benefit with hydroxychloroquine. And the FDA in the United States retracted the emergency use authorization of hydroxychloroquine and essentially said there is no benefit to the use of hydroxychloroquine. So as it stands now, today, hydroxychloroquine and ivermectin, which was also part of the study, are not recommended, demonstrating 0 benefit in the treatment of COVID-19. So then what works or what is available? So clearly, we first learned that hydroxychloroquine, chloroquine were not an option at all. People looked at antiretroviral therapy. So lopinavir, ritonavir is an antiretroviral agent used, and its claim to fame was its pregnancy safety. And we use it, we used to use it in HIV in pregnancy. We don't anymore because there are better drugs available now. But that was tried, and that was found to be not useful. There were a number of other agents which were looked at, so ivermectin being one of them. There were some other antiviral agents looked at. None of those worked. And most recently, as I will show you, that the IL-6 inhibitor, so interleukin-6 inhibitor tocilizumab, which is a monoclonal antibody which is used to bind against IL-6, which is believed to mediate the cytokine storm. has been demonstrated to be useless and so doesn't work. So the only thing that works is a drug called remdesivir. So remdesivir was an investigational drug. It is still awaiting final approval by the FDA, but it has emergency use authorization in the United States, made by the manufacturer Gilead. It was originally used or discovered for its use against Ebola. Found to have no effect against Ebola virus, the drug was actually shelved. And then someone decided to try it against coronavirus and essentially found that it has some effect. And I'll show you what that effect is momentarily. But people have looked at other drugs, favipiravir, which is still investigational in the United States, not commercially approved. Ribavirin has been found to have no effect at all. So remdesivir is basically an adenosine nucleoside, and it was looked at for Ebola, as I mentioned, but now found to be effective, COVID-19. So it's an intravenous formulation, 200 milligrams intravenous as the first loading dose, followed by 100 milligrams every day for the next 5 days. So the 10-day course was believed to be people who were more critically ill. They were recommended to get the 10-day course, and other people who were less ill to get the 5-day course. There have been comparison studies looking at 5-day and 10-day treatment and found that the 10-day course does not confer any additional benefit. And so now we have standardized it to 5-day course for everybody. Also recall, as I mentioned earlier, we've started using it much earlier in the illness. It has no direct antiviral activity, but the effect seems to be to shorten the duration of illness by about 2 days. The study published in the New England Journal. So this is a Kaplan-Meier, it's also called survival analysis. So it is time to event. So at time 0, there are no events. And as you progress, every event is marked by a step. And so you look at the steps. So you're essentially looking at 2 different curves that divide over time. So as you look at the survival, if you look at the people receiving oxygen, the people who survived were much higher in the remdesivir arm compared to placebo. People who survived overall were much better in the remdesivir arm compared to placebo. Patients not receiving oxygen, patients receiving high flow oxygen, ECMO, there was basically no difference whatsoever, or actually people in the remdesivir arm did worse, essentially, which is why ECMO is sort of terminal and of marginal value in and of itself. A person who requires ECMO, by that time, the odds of recovery are 1% or less. So essentially, this was what led to remdesivir being used initially for compassionate use and now being manufactured and used probably worldwide to as the only available agent right now, which would have some effect in reducing the duration of hospitalization of patients with COVID-19. So this is, again, people who did better with remdesivir. You clearly see the difference with the number of people who fall to the right of the midline, essentially showing benefit, and to the left of the midline showing harm. Anywhere where there is a crossing of the midline indicates no benefit or harm or not statistically significant. So clearly, remdesivir is one of the others. Lopinavir, ritonavir, as I talked about, has really been debunked and no longer recommended. A number of other antiviral agents have been looked at. A number of other antiretroviral agents have been looked at, none of which have demonstrated benefit. And as I mentioned before, chloroquine, hydroxychloroquine, all of them have not demonstrated any benefit at all. A word about interferon, which I'll come to later to talk about interferon, but interferons are being looked at and we'll talk about it momentarily. I mentioned the IL-6 inhibitor or interleukin-6 inhibitor, tocilizumab. So MAB is the monoclonal antibody. So it's a monoclonal antibody, which, and I remember interleukins are one of the biggest mediators of the inflammatory cascade. So that's part of the immune response, also called the cytokine storm. And it's believed that if you downregulate the interleukin-6 production, you would downregulate the cytokine production. However, the manufacturer of IL-6, Roche, came out with their own study and essentially demonstrated no benefit of IL-6. And so IL-6 has fallen by the wayside. It's an extremely expensive drug. And so they continue to study it, but essentially as of today, no one will use IL-6 inhibitors in the US at least. And so people move to other agents The large study from the UK using dexamethasone came out around this time. And so dexamethasone has now become the mainstay, much cheaper, more affordable, and definitely works to mitigate the cytokine storm. You could use it for much longer periods of time. This was only a single dose could be used, and that was about it. So what are the benefits of interferon? So interferon, recall, is the agent secreted in our own body to fight viral infections. So people said interferon is released so that when we have a common cold or a flu, we get the muscle aches, we get the feeling ill, we get the runny nose, we get all of that. What is that due to? That is actually due to the interferon being secreted in our body. It's interferon which drives those side effects that we see. So people said, okay, then if interferon is an antiviral, interferon should be useful in controlling COVID-19 multiplication, and so we should be able to use interferon. So people looked at it based on two sets of male twins, one from the US and one from the Netherlands. And people looked at, so that is there some reason why in both these twins, one died, one survived, and both were studied for potential genetic makeup to understand what happened to their interferon production and did it really translate into benefit. And what they demonstrated was that there is a subsection of people in whom there is an inadequate amount of interferon production. We don't understand who and why that occurs. That's up to as high as 12.7% in men and as low as 2.5% in women. This is one of the other hypotheses why the disease occurs more frequently in men, more severe disease in men, because the interferon production is attenuated and so the cytokine storm is not controlled. What also was found is that COVID-19 has the ability to secrete interferon silencing antibodies, which basically shut off the production of interferon in the host, thereby allowing unchecked multiplication of the virus, leading to the viral replication followed by the cytokine storm. And so therefore, it was felt that if what people are studying now is to see in which category of people can we use interferon administered therapeutically to boost the production of interferons to control the viral replication. The challenge is that in some people, the administration of interferon leads to interferon neutralizing antibodies, which essentially kill interferon, leaving these patients more vulnerable than they would have been if they were not administered interferon. So that's the challenge, to find out who would probably respond to the use of interferon and who would not. Clearly, everyone would not. And the risk is that by universally giving interferon, we may actually worsen disease because you induce interferon silencing antibodies and basically kill the interferon, allowing virus to multiply. So interferon being looked at, it's the hottest area of research right now. And so more to follow. We don't have a consensus as to who to use it in, how to use it. That is still being studied. The drug is currently available and obviously used in other indications. So to date, no specific drug or combination, which is antiviral. Remdesivir decreases the length of stay, as we talked about, steroids to mitigate the cytokine storm, and that's about all that we have. The rest is supportive care. So outcomes, mild disease, clearly people recover. Moderate disease, some people recover. Severe disease, less so. More people may lead to more comorbidities and potential death, including ICU stay. In the United States, there's been documented to have the mutation, probably the only known mutation. So the US version of coronavirus 2 or SARS-CoV-2 is different from the original Wuhan because of mutation at the 614th position. It's an aspartate, that's D is aspartate to G guanine. Remember the aspartate, guanine, thymine, and cytosine, the 4 genomes. So the mutation at the 614th position confers increased aggressiveness of the virus, increased infectivity, but has no bearing, as we understand today, in terms of mutational resistance. So it does not require a change in vaccine component. That's why the vaccine studies are progressing as usual without any interruption. This mutation has not affected that at least for now. So what do we do with our patients once they've been infected? So our recommendation here in the US, which we apply, is 10 days from the onset of symptoms or 72 hours of no symptoms, the person is considered free of infection and allowed to return to normal circulation in terms of work, et cetera, et cetera. The standard precautions apply, but they no longer need to isolate or quarantine. We do not do a test of cure, as I alluded to earlier. We would do antibodies for such patients if we wanted to demonstrate immunity. Antibody testing is fraught with challenges, primarily because there's a lot of cross-reactivity from exposure to prior coronaviruses, the common cold being the example, and plasma proteins. So the sensitivity and specificity of antibody tests is critical to be able to make an accurate diagnosis. And so that's why we don't use it for purposes of diagnosing the disease. We only use it for purposes of demonstrating immunity. Such patients are encouraged to donate plasma so as to be able to transfuse what's called convalescent plasma. There is criticism about plasma, and I'll address that in a moment, but essentially we are moving away from plasma at this point in time here because the belief is the risk outweighs the benefits. So that brings us to, before I go on to vaccine, to comment briefly about what's the challenge with plasma. So we understood that, so we were part of the largest study done by the Mayo Clinic, 35,000 recipients across the United States. We did about 80 patients at our site who got a unit of what we call convalescent plasma, plasma obtained from a patient who had recovered from COVID-19. So when these were transfused, we were blinded to who got it's an open label study, but we had no control arm, but we had no control over what the plasma and from whom it was received. So when the results of the study, which was recently analyzed and released, what it demonstrated was that there was a huge variability of response to therapy. We saw that in our own site, and that was demonstrated elsewhere, that some people seemed to recover extremely well, but other people had virtually no impact whatsoever of plasma. So that led people to actually start measuring the amount of antibody levels in the unit of plasma. And they discovered that people who have mild disease generally have very low levels of antibody. And by the same corollary, some people don't develop antibodies at all who have very mild disease. The people who have more severe disease have much more robust levels of antibody. So therefore, plasma obtained from somebody who had had more severe disease seemed to confer a higher benefit because of a higher level of antibodies in that plasma compared to plasma obtained from somebody who had very mild disease. This also formed the basis of reinfection. We've had 2 documented cases in the United States. There's several in Hong Kong and other parts of the world. And the hypothesis is these are all people who did not mount enough of an antibody response or no antibody response. Often, most of these folks had very mild disease. And so therefore, severity of disease is proportional to the degree of antibody response, directly proportional to plasma. So this led to the NIH giving a recommendation stating that the risk of plasma-induced transfusion reactions, transfusion-associated lung injury, the risk of anaphylaxis, etc., outweighed the benefit of giving plasma, and the plasma was felt to be an interim measure before vaccine came out because it would conceptually be the same concept as manipulating antibodies to develop enough antibody levels. So once the vaccine is available, plasma will essentially cease to exist as a therapeutic modality. So that's the story on plasma. So we are now into vaccine. There are several candidate vaccines across the globe. All of them focus on the spike protein. The spike protein, there is a domain called the RBD, the receptor binding domain on the spike protein. That's the most antigenic component and which is integrally required for the virus to bind to the human host cell. And so all vaccines are targeting the RBD, the receptor binding domain on the spike protein, and that's what the vaccines are being developed against. So there are at least 3 different types of vaccines in existence: the standard nucleic acid vaccines. There are what are called viral vector vaccines, so using something like an adenovirus or some other type of virus, which will then go into the cell and transfer attenuated or a portion of the RNA of the COVID-19 into the host cell and induce production of antibodies. And then there are the standard protein-based vaccines. So that's the 3. What's the basis of vaccines? So the vaccine component essentially delivers COVID-19 RNA into the host DNA, induces an antibody response. And so once that antibody response is present, the basis of that is when challenged with disease, the antibody response being high will be able to fight the antigen and confer immunity. So that's as simple-minded. How that antibody response is induced is what the 3 different mechanisms of vaccines that you're looking at today. So even India is a candidate for one of the vaccine trials. There's a Russian vaccine and the AstraZeneca vaccine, which is in collaboration with the University of Oxford. The plan is to develop the vaccine commercially at the Serum Institute of India in Pune. 100 million doses are planned to be produced, at least half to be used in India itself and half to be used outside. Now that may change, but as of now, that's the proposed plan. So all over the world, these vaccines are being developed. This is the fastest time when a vaccine has ever been developed. The usual time frame is 4 to 7 years. We are looking at somewhere between 8 to 10 months from the time of knowing about this infection to developing actual vaccines. So there are concerns raised about safety, etc., not being studied. So all these vaccines are looking at in their phase 3 trials, which are underway right now, are looking at about a cohort of about 30,000 healthy volunteers. In that, there is a proportion who are elderly, there is a proportion who are of different ethnicities, and a proportion male, female, etc. About half of them are getting vaccine, the other half are getting placebo. The target is at least 60% of folks should have at least 60% antibody response. The lower level should be less than 30%, would be considered no response at all, adequate. And what the goal is that once they've been given vaccine, they'll be challenged to disease and to see if they actually develop disease. And you want to see the number of events and what are the events. So they want to reach a pre-specified number of events to determine whether the vaccine is efficient or not. And so that's what the analysis is. What are the events? The endpoint events are basically symptoms of COVID-19, and they want to be able to demonstrate that based on that the person actually developed active disease, or at least a mild version of the disease, and that the vaccine worked. Thus far, based on phase 1 and phase 2 trials, they've been sort of 100% successful at least, but they are small numbers, 10, 15, 20 patients. This is the largest trials, so they're still underway. We don't have final results or even interim results yet, but that's what's being done from a vaccine standpoint. So more to follow. We also don't know whether they will be single dose or 2-dose vaccines. There's definitely the Pfizer vaccine is a single dose vaccine as we understand it. Others are 2 doses required probably a few weeks apart to induce enough of an immune response. How long that immune response will last, whether it's 6 months, whether it's a year. So will this vaccine need to be redosed semi-annually or annually is all undetermined right now. And so more to follow on all of those questions. A brief snapshot of where we are in the US before we wrap up talking about public health issues. So in the US, still the #1 country in the world. We have the highest spread. And part of our challenge has been that if you look at all the other public health measures of all the other diseases in the US, COVID-19 has taken over in a dramatic proportion. It's the #1 public health problem in the United States today. All other diseases compare. And worldwide, it's now become the #1 public health problem. Problem in the US, a lot of people who question science, people poo-poo it and say they don't believe in it, that this virus is a hoax. It was released by the Russians. It was a Chinese conspiracy, blah, blah, blah. There's all sorts of nonsense that people think. And so as a result, people there is this constant battle between science and the anti-science folks, as we call them, which is why there has not been widespread adoption of public health measures. One of the biggest challenges in the United States is our testing capacity has not matched our demand. We continue to have a perpetual shortage of reliable testing that is available for consumption. So the demand far outweighs the availability. And so we're constantly rationing tests and trying to make a diagnosis with clinical symptoms and other imaging or other ancillary testing, which is often challenging. This is data provided by Tony Fauci, Dr. Anthony Fauci from the NIH. He presented this at a recent meeting at which I was also able to attend. And he demonstrated that just by doing a lockdown in Europe compared to the United States, the effect of a lockdown was many states in the US refused to enforce a lockdown, while in Europe, there was a universal lockdown. As a result, the number of cases dramatically dropped, while in the US, there was a little bit of a drop in the northern part of the country. So here in Massachusetts, New York, etc., the southern part of the country, Florida, Texas, etc., it ran rampant. And so that's why we had a huge surge with very little impact on that. Same way, if you looked at all the other issues compared to the European Union, you look at the United States, the number of new cases, dramatic increases in cases, as you've seen, and as you're well aware, what our challenge is. We have issues with ethnic differences. The African American population, it's believed that there are some genetic differences which make them more susceptible to infection. There are also lots of socioeconomic differences, much as the same you see in India. Poverty is directly related to the inability to distance, the inability to maintain proper precautions, use of personal protective equipment, etc. And as a result, there is more spread among poorer communities. And that's noted here in this graph, clearly showing that an affluent population had much lower number of cases compared to the other populations, which were much poorer. We also had to teach people in the United States that shaking hands was not an option. So as we said, the namaste became the new way to greet. So we taught them the Indian way of greeting. And then the Japanese way of greeting, waving, foot tapping, elbow bumping, etc. So teaching people to stop shaking hands was one component which we continue to do. A lockdown. So clearly demonstrated that a lockdown is not sustainable on the long term. And so quarantining people only works so far. People need to move around. The economy comes to a standstill and people starve to death because the economy just gets paralyzed. It's not sustainable in any long-term fashion. So there has to be alternatives to quarantining. In the US, dining out, eating in restaurants is very popular. And so we had to put, for several months, there was an absolute shutdown of all restaurants, no indoor dining. And now it's very limited capacity. So somebody drew this of the Last Supper with a little hand sanitizer and all the disciples all separated in distance from Christ. So to basically demonstrate that people needed to maintain distance and not be large groups within an indoor setting. Vacations got canceled. So parts of the country like ours, where there are beaches, people love in the summer to go sit on the beaches. So all travel was, so somebody took a picture of this, put 2 sausages on a plate and took a picture trying to show that they were actually on a beach, essentially trying to make fun of the fact that vacations had totally come to a standstill. And we had to quell anxiety. People were paranoid about coming into hospital. Our number of preventable deaths went up because people delayed care because they were afraid, thinking that hospitals are the hotspots for infection, that they would die of COVID if they came into the hospital, and so stayed at home. And so we had calm, but obviously not enough calm. We led to some cardiac arrest, definitely. Our biggest challenge right now is schools. How do you reopen schools and allow children? So there has been lots of challenges. Harvard was among one of the first universities to say, oh, we will absolutely bring all our students back and we will be doing in-person classes. We will do frequent testing. But as was quickly apparent, teenagers and youngsters in their 20s do not understand the concept of social distancing, or rather they understand but refuse to believe that they are required to do that. They feel that they are immune to any form of COVID. And so we had college parties, we had backdoor parties. And so every college had to shut down and go to remote learning to prevent a spread. So we have seen a surge in COVID-19 in the state of Massachusetts because we are a big college state. We have over 30 states. In Boston alone, we have 30,000 students who move in and out each year into all the colleges because it's a highly educational town with lots of educational institutions. And so people have looked at phased reopening. People have looked at rotating schedules. Some are there in the morning, some are there in the afternoon. So people have gone to hybrid schedules. 2 days of the week, they are in-person classes. 3 days a week, they're at home. Another cohort comes in on the opposite days. So people have looked at all sorts of different options to be able to try to minimize and to increase distancing to prevent spread. So the school teachers, and my daughter being one of them, who had to go back to teaching in schools, but a lot of school teachers have objected, saying they're being put at increased risk because these children who may be asymptomatic carriers are there in the classroom and are likely to spread virus to the older people. The other concern is they go home to their parents or grandparents and then can lead to spread and can lead to significant morbidity in that age group. So the question was, what could we do for others in order to mitigate the disease? So you've heard of what's called the flattening the curve. That's been talked about. Dr. Fauci initially introduced that term, but essentially this is the epidemic curve, also called the Gaussian curve after Carl Friedrich Gauss, who was a Swiss statistician who said that if you take any random variable, there is a median number and there is a spread around the mean. That spread follows a bell-shaped curve. And so that's what that curve is. And so the goal was to flatten that curve, that is, reduce the growth of number of cases, acceleration, as well as reduce the peak number, bring down the absolute number of cases. So what we call flattening the curve. So we had to work fast to flatten the curve. So hand washing, the 6 feet distancing, and practicing cough etiquette was sort of one of the basic things we started with, reminding everybody that they needed to do this. There were signs, there were public messages, we used television, we used radio, we used other social media, etc., to keep passing the message. What are called non-pharmacological interventions, staying home when you're unwell, respiratory etiquette, like I talked about, the hand hygiene, the cleaning of surfaces, etc., are all things that we've looked at. So people have talked about what's called inducing herd immunity. And the concept of herd immunity came from the US agricultural world in 1910, where we found one person found that cows were dying in large amounts because of a viral illness. And so they started slaughtering cows to prevent the spread. But then somebody said, no, what if we treat those cows and we make them immune to it? If you have a sufficient number which is immune, you get a herd of people who are immune who will now be able to stop the spread of disease because those people don't get infected. So you have now a clear zone around potentially people. So that was the concept of herd immunity that has since developed. And so the goal of vaccine development is to induce that herd immunity. So we've talked about everything in farm country. This is what we tell people, 1 cow apart. So essentially telling them that distancing occurs in all levels. But again, the exceptions to the 6 feet rule, as I said, is any congregate setting. So we limit the number of people. In a 1,000 feet area indoors, only 25 people are allowed. And in smaller areas, only 10 people are allowed. The exceptions to that is churches being one of them, weddings, bars, etc. are the exceptions. Masking. We had to teach people that if you wear a mask, you don't protect yourself as much as you protect somebody else, and you expect the other person to wear a mask to protect you. So teaching people that everybody needed to be masked, and it didn't matter what mask we used, as long as we used some sort of a mask which covered the nose and mouth. It had to be at least 3 layers of material which was reasonably absorbent, and which would cover the nose and mouth, was critically important. And they've demonstrated from the University of Florida, a number of folks have demonstrated the position of the mask on both the nose and face. And if the nose is not covered, what happens, how much of spread, have been eloquently demonstrated. This was a great study from Hong Kong saying that weddings, temple, and bar, these were the three main reasons for spread that people were. And so that's why we put a big moratorium on church gatherings and made it more virtual, because that's the critical piece, that people in a small setting, they are singing, they're chanting, or they're talking, or expressing their faith in other ways in a forceful, so any loud use of their voice, speaking loudly, etc., carries the virus for much longer distances than the 6 feet, and therefore the 6 feet rule no longer applies, and they become hotspots in terms of spread of potential virus. What did we do in our own hospitals? Every employee who goes into the hospital every day, even today, in the last 6 or 7 months, we have a temperature check taken. We have to sanitize using liquid soap at the entrance as we come in. Everyone has to wear a cloth mask from home. They get a clean surgical mask to wear once they're in the building, and they have to stay masked at all times. The only time that they can be without a mask is if they are alone in their own office with nobody else in the room. Or if they're eating or drinking, which is not in a small area, they have to be in a more open area to be able to eat their food, etc. So everyone gets a surgical mask. The only time we use N95 masks are people who are actually taking care of the COVID-19 patients, and people who are actually doing what are called aerosol generating procedures. So intubation, doing endoscopy, doing bronchoscopies, or any such sort of ENT surgery, any nasopharyngeal manipulation, such as for testing, etc., those people would use full PPE. Everyone else just uses a surgical mask. People are encouraged to use eye protection, which may be either goggles, or if they wear spectacles, that's fine, because we know that the conjunctival mucosa is a potential source of entry of virus. We limit our visitors, so all our visitors are screened. So we closed all entrances, opened only one. When they come in, they are temperature checked. And so the question has been raised, what's the value of a temperature check? It's the most insensitive measure of how would we ever pick up a positive patient. Probably none. We have virtually picked up only one person, one of our employees, who was genuinely febrile. Everybody else was not. But what it does is it creates a disincentive for somebody who's unwell to show up to work, because they know that they're going to get temperature checked. They're afraid they might get caught. So people then stay home, which is what we want to. And the same with patients who enter, or their family members who enter. The temperature check is sort of a visible way of disincentivizing them from coming to hospital when they are sick, and potentially putting both staff in the hospital and other patients at risk. So we do those sort of limitations, and then we clean equipment. So this was a recent study from South Africa showing that aerosolization from a patient who's positive and who's coughing can absolutely occur. So these patients go into isolation rooms. They are the only person in the room. And so people who walk in and out. So we were very creative. So in the ICU, for example, where people have multiple drips and lines, nurses have to go in and out each time. So the question was, how do we prevent each time they have to wear all their equipment, they have to go in, then they come out, then they have to hang it up, then they start all over again. So we put extensions on IV lines, pull the IV pumps outside the door of the room. So they are outside, so that the IV pump can be manipulated from the outside without having to enter the room itself, physically enter the room. And so we created hooks outside the door so that they can hang up their gown, they can hang up their mask. And so all sorts of different things. We created videos on YouTube to educate them how to safely don and doff, putting on a gown safely, taking it off so that they don't contaminate themselves while putting on their personal protective equipment, etc. So all of those were created, extensive education so as to be able to manage these patients. Clearly known that surfaces can transmit. Most surfaces are not really conducive. The exception is paper and glass, but no one has really demonstrated an outbreak from surfaces being transmitting infection, so to speak. And so that's why people, but we have still sanitized pens and people use gloves, etc. When we were seeing patients, we weren't allowing patients to come into the office. We did through the computer. There are several free programs where you can do what's called telemedicine. We are able to see patients, interact with them. They can connect as well. You can do everything but a physical examination. So you can look at them, you can talk to them, you can interact with them, etc. You couldn't do a physical examination other than look at a rash or something else like that. So many patients we were able to manage that way without physically bringing them in, decreasing the risk of bringing in active infection into the office. And so using computerized programs, we were able to interact with these folks. There was isolation issues in the hospital. So patient admitted, couldn't have family members come in. We didn't want them exposed. So we did using FaceTime on an iPad or an iPhone, using some sort of a program where they could directly FaceTime with their family members. That was one way we used to communicate with family members so that they could at least not feel a sense of isolation. Well, clearly there was a lot of education. We led to a point where we really didn't increase people's knowledge. Number of cases went up, the number of webinars, and obviously income dropped dramatically. Every hospital lost millions of dollars. A lot of us took salary hits because there was no way to basically sustain it during the pandemic. Our conferences went virtual, so instead of sleeping at the conference, they now slept at home and the webinar continued. But most importantly, our critical care resources were tapped. So here is just a comparative data to show that one of the biggest challenges which India is facing is ventilator shortage, even for a country like US. So in the US, rules were changed where under emergency rules, the president can mandate companies which manufacture other things to be forced to manufacture ventilators. So all the car manufacturing companies such as Ford, General Motors, etc., were told to stop manufacturing cars and start manufacturing ventilators to meet our shortage of ventilators. And so that was how we met some of our shortage of ventilators. Did the distancing actually help? Yes. So in blue is the area of people who were uninfected. In red is the infected and the people who've recovered. And you notice that from no distancing, quarantine to significant distancing, clearly the uninfected numbers proportionately go up, essentially suggesting that distancing is successful and is a good public health measure. So lockdown, as I mentioned before, is just not a sustainable measure. It leads to huge economic downturns and happened here in the US as well. There was a lot of criticism about states which mandated a lockdown. We had nursing homes which were completely locked down. So we had the elderly who were completely locked down because it spread through nursing homes desperately, like wildfire. Our elderly population got decimated by the number of deaths from COVID just because of the rapid spread through nursing homes because they didn't have enough precautions. And what's most concerning is the asymptomatic carriage. So cruise ship industry has taken a huge hit because there is a huge number of asymptomatic. The question is, how much is asymptomatic carriage? And the feeling is asymptomatic carriage, based on this study, is up to 40% of people can be asymptomatic carriers for 48 to 72 hours prior to their manifesting with symptoms. So it's a staggering number. And so the value of use of masks, the use of distancing cannot be overemphasized and is critical to help prevent the spread of infection. So we had to have a lot of public service announcements, use common sense, people need to protect each other, etc. And so we said, we are not here to promote fear, but we're here to cause really growth in mindset. People needed to be responsible, that we live in a community where we need to protect each other. Everyone's actions has direct effects on others, and that's what we kept teaching. So this was an interesting slide I saw in somebody's presentation. Follow women, not follow and avoid men, not in the literal sense, but in the acronym that is shown here, which was a humorous way of educating people about what was the right thing to do. But clearly what is now being looked at is the psychological effects of the impact. So we know that the time when this whole pandemic hit, everybody came together, people were working around the clock. My average day was 16 to 18 hours every day, 7 days of the week for at least 6 months of the year that this was going on. Even now I work 7 days of the week, but at least not to that many hours. But essentially the adrenaline flow and people were working together to try to mitigate this. But what people are realizing now is that there is a huge disillusionment, the loss of income, people who've gotten sick, including physicians who've gotten sick, the number of physicians who've died taking care of patients. We've had suicides from people who were burnt out from taking care of patients with COVID-19. So there is a huge stress and fatigue factor which is set in. And the fear is if there is another major surge in illness like the last time, we will not have people who will be available because people will choose to retire and move on rather than be forced to care for such patients again. And the same with our nurses. So it's a huge challenge. So this is being looked at, wellness strategies to be able to care for physicians and to help them get through this process and be able to care for themselves so as to be able to care for others. So our responsibility lies not only in the clinical care of patients, but also in the public health measures and educating the public, because that's probably the more cardinal way of preventing or mitigating the risk of transmission of disease and protecting all of us as a community. With that, I will stop and I'll entertain questions. I'll stop sharing my slides and we'll go back to questions.
Thank you so much, sir, for that wonderful presentation. We are really delighted and extremely grateful to you for this session. Now, may I call upon Dr. Joseph John, sir, to take up the moderation session.
Thank you, Jacob. Time being at a premium, I would like to thank George for the crisp presentation. And I would like to go straight to the questions rather than anything, rather than going about the topic any further, because this talk has been rather comprehensive and most of the things, it has brought about certain important things like the timing of remdesivir, the timing of steroids, all this very crucial roles in instituting these medications at the right time of the illness for their maximum effect in saving lives. He also took us to the various modalities of investigations, like how an anterior nasal swabbing technique would suffice rather than what we currently use. And the important low cycle threshold is considered something to be taken with a pinch of salt, how it can still be relevant in determining a high or a low burden of virus in patients who are being tested. And especially, he brought forth the importance of the need for antibody testing and what its relevance is to interpreting our RT-PCR tests. He also delved on the treatment strategies, the convalescent plasma, and what challenges lie with the development of vaccines, besides an overview into the new normal. All these are challenging, and I will straight away go forth to a few of the questions raised by our viewers. Shall we go ahead, Dr. George?
Please.
Right. There's one question. If a patient is hypoxic, do we need to continue them on oral steroids at the time of discharge?
No, they would be, we would stop them by the time. They wouldn't be discharged till they are ambulating enough and their oxygenation levels have returned to normal where they can uh, be discharged on room air. We would not send them home on oxygen. And so we would stop steroids at that point in time. The presumption is by then the cytokine storm is over. And so there's no value to steroids.
Okay. Second, if the D-dimer is high at discharge, do you continue anticoagulation either as an oral anticoagulant or as heparin?
Yeah, so the way we use anticoagulation is we don't go by D-dimer as a measure. Recall D-dimer has a high false positive, false negative rates because it behaves a bit like an acute phase reactant. So because of that, we usually, if they are so standard, everybody will go on anticoagulation, just standard dose of anticoagulation if they're hospitalized for COVID-19. We would do 1.5 times or twice the rate of anticoagulation if there is concern for any vascular events, a TIA or a thrombotic event of any sort, or if we were to demonstrate venous thromboembolism or some other manifestation where we were concerned about vascular inflammation and highly concerned about potential risk, then we would do. Recall the reason for that is because when you do higher dose anticoagulation, you obviously run the risk of bleeding. And so you're balancing between the risk of bleeding versus the risk of clotting. And so where the risk benefit analysis demonstrates a benefit to the anticoagulation, then we would proceed in that fashion. But the D-dimer is a poor guide to be used for coagulation in general. And so we don't use that at all.
How long would you like to continue these patients after discharge on
anticoagulation?
anticoagulation?
Yeah, so generally not. We don't continue. There have been small case reports from New York of people developing stroke-like symptoms a few days after discharge, which means after they have recovered. It is not clear whether that was related to COVID-19 or was coincidental or otherwise. And so the general recommendation is anticoagulation, steroid use, all of that would be discontinued at the time of discharge, that patients would be sufficiently well where they don't need any of that and they'll be discharged without any of that.
Thank you very much. The next question from Medha Vijaykumar is, why are adenoviral vectors being preferred over others, like AstraZeneca uses modified chimp adenovirus vector?
Yes, so good question. It's just what each company is experienced with. So adenoviral vectors was used for other vaccine development in the past, and modified chimp is one of them. Adenoviral, Merck has used a different vector, the simian, the chimp vaccine vector, because they tried it in Ebola. They have an Ebola vaccine currently under development. So it's just based on whichever vector they have experience with, because they don't want to recall time is of the essence. It's a bit like everyone is racing to the finish in terms of trying to get a vaccine available. So they want to go with tried and tested technology rather than slip up with choosing a novel technology, because so much of this is already novel. And so that's why everyone is going that route. Everybody's trying to broaden the demographic of the population that's being tried. Not only healthy volunteers, people want to use the elderly, people want to use different ethnic groups, people want to use immunocompromised hosts. So a wide variety of people are being used because the dosing, the frequency, the duration of effect, all of that may vary in those populations. And so the recommendations for vaccine dosing, et cetera, may change depending on which population is being studied.
Right, Dr. George. A question from the Believers Hospital. At Believers, we use a very sensitive RT-PCR machine called TrueNat. But patients who turn positive go to retest in other centers, which have a much lesser sensitive machine, and turn negative soon after. How do we handle this? Can we do an IgM antibody test if it turns positive and RT-PCR is positive too? Can we confirm that the person is infected, though that is another machine, though in another machine elsewhere?
Yeah.
They turned out to be negative.
Yeah, excellent question. And so it comes back to, let's look at one fundamental principle in sensitivity and specificity. So sensitivity means you're lowering your threshold to be able to pick up more number of tests. So use a classic example, blood glucose. If you were to use for diagnosis of diabetes, instead of a blood glucose of 126, you were to lower your blood glucose to 100 or 110, what will happen? Everybody between 110 and 126 now becomes diabetic. If on the other hand, you were to increase that from, instead of 126, you were to say 140 is your cutoff, then everyone between 126 and 140 would be considered non-diabetic. So that's the principle of sensitivity and specificity. So sensitivity, when you increase the sensitivity, we cast a wider net, we pick up more people. So in that portion, there is a proportion who might be false positive, and there is a proportion who are true positive. So in people who are RT-PCR positive by a highly sensitive test, a lower sensitive test obviously is the difference in threshold, which makes that latter test negative and the former test positive. So correct, the use of an antibody such as an IgM antibody test would be useful in this situation. And the way it would be useful is, as I demonstrated in the slide, was that by the time they are antibody positive, they should be viral antigen negative, or at least they are beyond the viral phase of the illness. So if they are antibody positive, they are basically, those antibodies do confer immunity. They are not marker antibodies. They are protective antibodies. They confer immunity. So when they confer immunity, any PCR positive test at that point in time would be considered positive, viral, persistent, inactive antigen, and not suggestive of true infection. The antibody test would be, assuming your antibody test is accurate. And that's the second challenge, because the antibody tests have their own problems in terms of cross-reactivity. So assuming the antibody test is accurate, then that is proof of immunity. They're not considered infectious. I do not then we don't look at the antigen test anymore. The PCR test would cease to exist in terms of use.
Thank you very much, Dr. George. One question, I shall just reword it, is from Marmon Paul. We have done antibody testing for seroprevalence. Why can't we use it for individual testing?
So antibody testing, unfortunately, is not the right test for seroprevalence. So the presence, the fundamental reason is this: as you recall, we are testing for coronaviruses. The coronavirus family is large, common cold being the commonest and largest member of that family, and others being much smaller groups. So the problem with antibody testing is there is cross-reactivity with other coronavirus proteins. So often the seroprevalence would be clouded by a false positive rate, which is usually unacceptably high. And so therefore, even in the US, antibody testing is only recommended in the setting of somebody who has been diagnosed to have COVID-19 by a PCR-based assay. So that there you know for sure that if they test positive, given the immediate precedence of having a positive PCR assay, that would be when you would say that test is truly positive as opposed to a false positive. And so we do not, in the general population, we use PCR assays for seroprevalence. So even today, we do thousands of tests a day on random people, asymptomatic, symptomatic, etc. And the PCR assay, anybody who tests positive would be considered active disease or asymptomatic carrier, not an antibody test. In this situation or in this disease, an antibody test unfortunately does not serve the purpose of establishing seroprevalence as we would in other diseases.
Next question. If we are planning a convalescent plasma therapy, shouldn't antibody IgG testing be mandatory?
Absolutely, without question. So we also do. So our Red Cross does most of our plasma donation because they are set up for plasma donation. So they obtain the plasma. Everyone has an antibody test performed on them. And unless they are antibody positive and meet a pre-specified threshold, they would not be allowed to donate plasma. That is correct.
Do you check the antibody levels only in documented patients, or do you check it, if required, in people who have not been infected, but who could have been a part of the asymptomatic?
yeah, again, as I mentioned earlier, we do not check in not documented patients because of the risk of false positive rates which occur from antibody testing. The no antibody test here is so perfect as to exclusively test only for COVID-2. Most of them cross-react among the 30 or more different antibody tests that are currently available. And so therefore, we test only in the setting of diagnosed infection.
Dr. George, a couple of quick questions. How would you treat the COVID-19 patients who have chronic renal and a chronic liver disease?
Yeah, excellent question. So remdesivir, so you're bringing up the point that remdesivir is contraindicated in somebody who has a creatinine clearance less than 30 mils per minute,
Yes.
and somebody who has an ALT elevation more than 5 times the upper limit of normal. So excellent question. We are often forced not to use it. You could theoretically do dose reductions and give it by 50%. But there is no data to support that giving it at 50% of the dose is efficacious in any way. And so unfortunately, in those patients, we do. We also daily monitor LFTs as well as creatinine on patients who are on remdesivir so as to be able to know when to stop treatment. And we often have to suspend treatment when their ALT elevation jumps up, which is dramatically high, or their creatinine suddenly deteriorates, we end up suspending treatment prematurely. So that's a risk. So unless those two are normal, you can't give them remdesivir.
And how do you diagnose a reinfection in case of COVID-19?
Yeah, excellent question. So reinfection would be only if you were to be PCR positive, antibody negative, and have symptoms. So that would be, so for example, the patients that I mentioned, at least in the US, there was sequential tests because this patient had originally been diagnosed and subsequently, as he presented with symptoms to other places, he had diagnosed negative tests. Now, that's not a recommendation. It just so happened in this patient, they had diagnosed, documented multiple negative tests, which demonstrated complete resolution of the infection, and then new symptoms leading to new testing with a positive test, and then they obviously quantitated virus, etc. So that's an exception. And so that would be, unless there is that complete trio of clinical symptoms, negative antibodies, positive antigen, all three present, reinfection so would not be diagnosed. So reinfection in general, you have to assume is exceptionally rare. It's not the rule. The larger majority do develop demonstrable immunity once they've been infected.
A question from Dr. Cyril Fernandez. Is remdesivir therapy indicated in COVID-positive asymptomatic patients in order to reduce community transmission? Well,
the answer is no. And the reason, as I pointed out, is remdesivir has no antiviral properties which directly mitigate viral replication. We don't understand clearly what its mechanism of action is. So the data for outcome was to reduce length of hospitalization. That was, so clearly it mitigates the illness in some fashion. We don't exactly know how, which is why asymptomatic patients, non-hospitalized patients, and in people to prevent transmission, it's not indicated. It's only indicated in mild to moderate infection. Severe infection, it can be used, but the outcomes are much poorer. Mild to moderate infection requiring hospitalization is where the optimal benefit has been seen, often with great success.
Thank you, Dr. George, for your lucid explanations. I think time calls for a closure here. And until we meet again, and before I hand over to Dr. Jacob, I wish to thank you on behalf of the Believers Church Hospital.
My pleasure.
I would like to mention a statement of Rudolf Virchow. As you aptly stated earlier, that we have to be involved in policy changes also. Rudolf Virchow once stated, medicine is a social science and politics is nothing else but medicine on a large scale. And to take a quote from Journal of Epidemiology in BMJ, which stated that medicine as a social science, as a science of human beings, has the obligation to point out problems and attempt their theoretical solution. The politician, the practical anthropologist, must find the means for their actual solutions. Thank you very much. And over to Dr. Jacob for the final comments.
Thank you, dear Joseph John, sir. And we are coming to a close of this session. We are extremely grateful as an institution to Dr. George Abraham, sir, who has come live just for us from Boston, Texas. Sir, thank you so much for that amazing session. We are all in awe, and we have taken a lot of take-home message so that we can tailor-make our mode of therapy in COVID. Thank you so much, sir. We really look forward to hearing more from you, more sessions from you. Extremely grateful. And I would also like to extend my thanks to our physicians, Dr. Joseph John, sir, and Dr. Philip Thomas, sir, for leaving their extremely busy schedule and coming in to moderate this session quite admirably and taking us through this wonderful webinar. So thank you to all the participants, especially our faculty and our beloved students, faculty and students from other institutions in India and abroad, all our international delegates and education partners. We are extremely thankful for this entire session to each and every one of the organizing team as well. So this is coming to a close, and be tuned for another webinar on October 3rd. We have an eminent professor from the National University of Singapore speaking to us. So until then, signing off from Believers Church Medical College and Hospital. Thank you all.
Thank you.